Welcome to this webinar. COME is really proud to be able to welcome tonight Christelle Nguyen and Raphaël Zegara-Parodi. We're going to spend probably an hour and a half together to not only oversee the whole process of the research that they've been running for the last 11 years, but also reflect and exchange on where do we go from here? What does all this mean? So first of all, I'd like to present Christelle Nguyen. She's a medical doctor who has also had a postgraduate degree in biology. She's done a PhD in biology. She did a postdoc in Australia, I think in Queensland, at Brisbane, if I'm not mistaken. She's actually Associate Professor of Physical and Rehabilitation Medicine at the Faculty of Medicine, Pierre Descartes, which is at the University of Paris, which is running a very interesting trial in a multidisciplinary approach. And she has a very translational approach in research, combining also knowledge from fundamental research and then pushing it forwards to clinical application. She's been working on the project for 11 years. She's, I think, an outstanding research to be able to outreach to also other professions, given her ability to obtain grants and work with teams. And I think it's a great pleasure that she had interest and was able to put up this trial with the team of osteopaths and bring this to the profession. We also have Raphaël Zegara-Parodi. Raphaël is a dear colleague who is also on the board of trustees of COME. I appreciate Raphaël for his curiosity, his ability to outreach to also other disciplines, but integrated into his vision of what osteopathy is. He's an editor at the IJOM. He did a postgraduate period at the AT Steel University, which I think confirmed that he had caught a very infectious disease called researchitis. I think he's been passionate both for osteopathic and research all along, working in different fields, including also trying to create and go also beyond usual boundaries in the biopsychosocial model. What did I miss for Raphaël? He's a clinical practitioner as well. And I think that's it. For myself, I will be your moderator during this, this presentation. So my name is Paul Boucher. I'm professor at the University of Applied Science at Fribourg in Switzerland. I'm also a board of trustee member within COME. And I'm an editor at Main Libre. And I have a full interest of also listening to all the exchanges on these topics. Not only do I feel concerned as a passion of research in osteopathy, but also in our thoughts of how can we develop our research and also create an identity in osteopathic science and where can we move from here. So for the practical approaches, so anytime during the conversation, if you suddenly have a question or so on, do not hesitate to use the Q&A button that you can find below and post your questions. I will make a selection from these questions and they will be then treated at the end of the presentation. You can also use the chat button if it's exchanges you would like to share with other people, which might be a small reflection, references, or whatever you want. So any of you can also keep the chat dialogue open, and it'll make it possible for you to also notice and chat as we move forward. The whole session is recorded. Also be notified that at the end when I'll give out the questions, I find it nice to be able to name who reflected on the topic. And so all these elements are recorded. They will be made available for you in a couple of days, usually using the same link. So if you want to get back to it and find different elements from the presentation, you are free to do so. So I think let's get started. I think you have a lot of interesting things to say, and thank you for both being here. Thank you for your contribution to the osteopathic world, and for also spending your time for quality communication, both on osteopathy and on science.
Thank you very much, Paul, for this nice introduction. And thank you again, Christelle, for being with us tonight in order to present not only the study, but all the discussions, the ongoing discussion within the profession. Because this study, as you all have seen in your different countries, has raised many questions. So hopefully we will give you more insight on the context, on how this trial was designed, how it was designed with the specific methods of the complex intervention, and how we can interpret the results in order to move forward. So first of all, I will give you a very brief overview of what's going on for the osteopathic manipulative treatment of patients suffering from low back pain. So basically, here you can read the guidelines, the American Osteopathic Association guidelines that are published and PubMed indexed, and it's part of the national recommendation. And they have described the osteopathic care as with a body-centered approach, with the practitioners looking for somatic dysfunction and treating somatic dysfunction in the hope that this will increase, this will improve pain and functional disability. So this is a very body-centered approach, and this has been used in other countries. However, if we have friends and colleagues from UK, this is the osteopathic practice standards. So it's one ethical recommendation in order to protect the public to use the best available evidence. So obviously, when we describe our work or a specific type of care with relying only on somatic dysfunction, at least we need to make sure that it has some evidence to back such claim. So it's the same. It's just a quick review of the definition, the legal definition of osteopathy in France. Those French decrees were published in 2014, so they are quite recent. And again, they have used a similar description as in the United States. They have used a body-centered approach, focusing on the detection of osteopathic dysfunction, and individualized. The treatment is obviously individualized, and that's the type of challenge we had to face when we had to design the specific treatment to investigate the research question. One interesting thing is that osteopathic technique is legally described as a set of gestures based on osteopathic principles. And I've looked very carefully in those decrees, and those osteopathic principles are not described. So it's quite, there's a lot of imprecision here, and that probably need to refine and to better define exactly what we're doing, especially when we refer to the osteopathic principles. So as many of you are aware, A.T. Still himself never gave a description of the osteopathic principles. He died in 1917, and it's only in 1922 that the first set of osteopathic principles were proposed. Probably I need to say that this work was done by a woman, Louisa Burns, from the A.T. Still Research Institute. She described this first set of principles, and those set of principles have evolved over time. They were reviewed in 1953 and then in 2002. And one very interesting feature is what's the object of the treatment, of the osteopathic treatment. You can see that in the 1953 principles, the target of the treatment of osteopathic treatment is the body. It's a very body-centered approach to osteopathic care. While in 2002, they describe a person as a product of an interaction between body, mind, and spirit, and the main target for osteopathic care is no more the body, is the person. So there's a slight shift in the main target of the osteopathic treatment. And interestingly, when we had to design the protocol, the evidence that was available in 2011 were relying mainly on those body-centered concepts. It means relying on the search and the treatment of osteopathic dysfunction or somatic dysfunction. So obviously in France, we now have a lot of work because those principles and foundation has to be critically appraised and based on the best available evidence, as every healthcare profession should do. So now we can have a look at the specific methods that were used to describe osteopathic care. I know many of you are familiar with other type of osteopathic treatments, and because this one was new and we receive a lot of criticals, and so we'll take the time to explain exactly what has been done here. So we have three different types of evaluation when we talk about osteopathy. The first is based on how to evaluate the manipulation. It means how can we evaluate the short-term or long-term effect of the physiological associated effects. So this was not the case here. So it's mainly physiological studies. Then we can have more clinical studies. And with osteopathy, when we evaluate osteopathic manipulative treatment, we are evaluating the specific manual component of osteopathic care. And it's very useful, especially as we have just seen in the previous slides, that we as a profession define ourselves in detecting and treating somatic dysfunction. This is the way we present ourselves. So we need science to back that. That's why we need this type of study. Third type of evaluation that is possible to perform in osteopathy is evaluating osteopathic care, meaning the specific manual effects of OMT and what we call the contextual effects. We'll describe those contextual effects later on during the presentation. So LC-OSTEO was the research question was to evaluate the specific effects of OMT. And there was the current limitation on what we relied mainly, as I've said, on the treatment of somatic dysfunction. However, this trial that was published in 2003 by John Lee-Chardonnay was one of the first to describe possible other active components occurring during osteopathic care. Because in this trial, patients couldn't make the difference between what osteopaths called osteopathic manipulative treatment, real treatment, and the sham manipulation. So there was no difference. So probably there was other effects such as the placebo effects. So the problem is in this trial, for example, the practitioners, there were students mainly, they were treating patients sometimes in hospital. There was a lot of confounding factors. So the thing is that obviously that were the results, but there was a lack of the methods were not that strong to conclude. Other interesting approach is that, again, patients cannot perceive the difference between what practitioners describe as a placebo and as a real procedure. This is a meta-analysis that was published recently, 2 years ago. And again, patients couldn't make the difference between sham manipulation, between soft tissue manipulation, between manipulation. So it means that it's becoming more and more difficult to present ourselves and to describe our specific skills with only body-centered techniques approach, because patients, they can't make the difference. But the thing is that we had to be sure to perform that. So that's why we needed to have a stronger methods in order to investigate the specific effects of OMT. So as probably you are probably aware that different types of interventions that can be used when we want to evaluate the OMT in a trial. The first is the standardized treatment, meaning that all patients receive exactly the same techniques, the same approach. So there's no individualized diagnosis. So it's super easy to, from a methodological perspective, but no one is using this type of approach in clinical care. So it's not that useful for clinicians. Another option is a mix, as a semi-standardized treatment. It means, I know that John Litchard had done that in one of his trials. It means patients receive 3 techniques and 2 other techniques based on individual diagnosis. And it could be anywhere in the body. It could last 10 seconds or 1 minute. And again, it's very difficult to interpret those results because there's a lot of confounding factors. One other option is the black box treatments. It means we treat, we're doing like we do in our clinical practice. We treat what we have a specific diagnosis and specific treatment. And the problem is if we it's super difficult to conclude because we don't have any clue why patients get better when they get better, and we have any clue when patients don't improve when they don't improve. So the problem, the main problem was how to generalize those results in order to inform osteopathic practice. So that's why LC-OSTEO, that's an acronym for lombalgie chronic low back pain osteopathy. We were lucky to work with Dr. Isabelle Boutron, who is one of the leading specialists in the complex intervention methodology, and she helped us design one specific osteopathic manipulative treatment in order to be very close to what we use in clinical care, and at the same time to get results that we can really interpret and use to if we want to have an evidence-based approach. So I let Christelle talk.
Yeah, so as Raphael mentioned, osteopathy is considered a complex intervention, meaning that it includes many components that might be active to relieve symptoms. So when you try to address a research question regarding a complex intervention, you have to make some design choices that are based on the intended purpose of the study. And so, as Raphael said, we worked with Isabelle Boutron team, and for the past, I would say, 15 years, her team has nicely shown the basic methodological differences between pharmacological and non-pharmacological trials. And this was the primary work where she assessed 110 papers. 50 were trials assessing non-pharmacological interventions, and 60 assessed pharmacological trials. And from this primary work, she could show that trials assessing non-pharmacological trials were of overall lower methodological quality according to the JADAT scale. That there was probably a problem with the lack of reporting of the methods, and we will see that her team further developed a reporting checklist to improve that reporting of methods of non-pharmacological treatments. Those problems with reporting mainly involved randomization, analysis, or reporting of adverse events. Of course, and it's a main difference with pharmacological trials, there are important choices to make about the comparative treatment. What is the right placebo? How can we ensure blinding of patients, assessors, practitioners? Those are sometimes limitations or of non-pharmacological trials that we have to take into account. And of course, the influence of the level of training of practitioners, as shown in the previous study that Raphael showed, can also influence outcome. So we had, when we design our methods for this LC-OSTEO trial, to take into account all these basic differences. Another thing is that, maybe you can move to the next slide. Another thing is that when designing and planning the clinical trial, assessing complex interventions, there are preliminary steps that are compulsory to design the right interventions to address the purpose of the study. So we as nicely summarized in this figure of the MRC that has been updated recently. There are basically a first step that we worked on with Raphael and all the osteopaths involved in the study, which is the development of the intervention. So we had to make a preliminary work of identifying the evidence base, identifying, developing theory and modeling process and outcomes. Then the second step is to test feasibility of procedures and all the determining sample size and recruitment. And only after all these steps, we can really conduct the large-scale randomized control trial. So these steps are really important to design the right trial. And so that's probably why we were able to really properly address our research question, because we took that time to design in the most appropriate way our trial. And then probably that's the next step, how now we move from the results of the clinical trials and how these results can be maybe implemented in clinical practice. And that's probably where we are now, and we will move on from the results of the trial. And so that's the last point, methodological point. So as I mentioned, the reporting of non-pharmacological trials is probably a bit more difficult, of course, than drugs or any pharmacological trials. And we based our reporting on the consort statement, which Isabelle largely contributes to the development of this statement. And the challenge of reporting transparently and comprehensively complex interventions, it's that first, readers can really understand in a comprehensive way what we really assessed as interventions and control, and of course being able to replicate in other contexts our findings. But what I would like to say is that in the design of a trial assessing complex interventions, there are no perfect design choices. And we tried our best to justify, based on evidence available, all our design choices. So that's what Raphael introduced, but we really made that effort for each aspect of the trial. So basically, our trial aimed to address a single question. So that's a point that might be a bit frustrating when you conduct a clinical trial for 10 years, that you might be able to address only a single question. But again, we conducted the trial and designed that trial for a single intended purpose, and that was to compare the efficacy of standard OMT versus sham OMT for reducing low back pain specific activity limitations at 3 months in people with non-specific subacute or chronic low back pain. And yeah.
Thank you, Christelle. I'm going to explain how we have designed the both treatments. So first of all, we, like Christelle said, so the methods of complex intervention, they are used to improve the reporting and to help not only scientists, but to help clinicians to make sure that the care they provide to patients have the best available evidence. So this is I know if we have colleagues from the UK, it's a mandatory requirement, but for us, for example, in France, it's not very established. So in the OMT group, so that being said, so we really wanted to make sure that those treatments were backed by science and were commonly used in clinical care. So we have designed the OMT group is one standard, and standard for those like me who are not native English speaker. Standard means usual care, and it doesn't mean standardized. Okay, so it could have been, we could have said one common, one possible OMT, and as Christelle said, many other options were possible, and we have chosen the options that were mainly backed by science, by the science that were the scientific publication that were available when we designed the trial. It means 10 years ago, and as you all know, a lot of things have happened in the manual therapy field over the past 10 years. So in the OMT group is one standard OMT, and the treatment was individualized and based on the diagnosis of somatic dysfunction, exactly like the AOA guidelines and exactly like the French decrees are reporting and describing what somatic dysfunction is and what an osteopathic treatment should be based on these body-centered models of osteopathic principles. The sham OMT group, it was a placebo of OMT, was light touch, and this treatment was standardized. This means that all the patients had exactly the same treatment. It was a very light touch and over the whole body. So in this table, so for those of you who want more details, so we have there's an appendix of the papers, 45 pages, describing exactly all the different aspects of OMT and the sham OMT. Here is just a table to summarize the main things, and that each visit lasted 45 minutes, and each visit had the same outline. And some parts of the osteopathic care were exactly similar. So between standard OMT and sham OMT. The therapeutic context was exactly the same. It lasted around 10 minutes. The diagnosis procedure means each osteopath had to evaluate the whole body, the whole musculoskeletal system and abdomen in search of somatic dysfunction. Was exactly the same in both groups. It lasted around 10 minutes. Then, obviously, the therapeutic procedure were different. If patients were included in the standard OMT, they had a specific and individualized OMT based on the specific diagnosis of somatic dysfunction in 7 areas of the body. While in the sham OMT, patients, they had the exact same clinical examination, but they received exactly the same treatment. That this treatment was standardized and not individualized. Then the clinical recordings, 4 minutes for each group, and therapeutic, the dosage was 6 sessions at 2-week interval. So I know there was a lot of questions. So probably Paul may answer at the same time, as I can't see that right now. But this was based on the UKB trial. They use exactly the same interval. So like Christelle said, each choice was supported by available evidence at that period of time. So the practitioner characteristics. So all the practitioners, they were like me, means in France, a non-healthcare professional with a 5-year full-time training. And all those practitioners, they had to follow a 2-day specific training. And at the end, they had to pass a kind of evaluation in order to become practitioner of the study. So if we can go into specific components of the choices and how we have designed the trial for the treatment group. This is one very interesting thing, and we'll have a discussion after that on where do we go from here. Personally, this is one key point from this trial, because this type of algorithm has not been, to the best of my knowledge, has not been published in the manual therapy field. It means that it's a real good combination in order to have a strong methods. Strong methods allow to collect data that are very helpful for clinicians. And at the same time, it really describes what can happen in clinical care between a patient and his or her osteopath. It means that we had chosen 7 different anatomical areas, and the practitioners has to evaluate whether they found clinical signs of somatic dysfunction. We'll see that later. Tenderness, restriction of mobility, and so on. And if there was a somatic dysfunction, according to the AOA guidelines and to the French decrees, they were supposed to treat this somatic dysfunction with one primary technique. And if this technique was painful or not possible for any kind of reason, there was a possibility for an alternative technique. And then the second, and if there was no somatic dysfunction, there was no treatment, exactly like we're doing in clinical care. And the same process for each of the 7 areas. So this way, I remember this was a meeting with Dr. Boutron. She's totally aware that with the same symptoms, patients who are wants to have a complex intervention, such as osteopathy, or it could be acupuncture, or it could be psychology, same symptoms, they will have different treatments. And the diagnosis might change between one session and the other. So what she asked us is make sure that one patient visiting one practitioner with this algorithm will receive the same type of care within this body-centered approach. And we have a discussion because there was some limitation. So why have we chosen 7 anatomical areas? So that's just an example to show you that I think every choice was backed by science. So it's simply a descriptive study, epidemiological study that was performed in the US with 3,900 patients of data recordings from clinicians. And most of patients, 35 patients, they have 7 to 8 body regions treated during one osteopathic treatment. Why we have chosen the sham, the light touch as the sham treatment? Because it was chosen for the MOPSI trial, the trial that was performed in the US too, evaluating the effect of OMT on pneumonia in elderly. So this was already used in another trial. And again, with bearing in mind that with science available at that time, were highlighted that the main active components of treatment was the specific effects of techniques. So that's why we have designed this trial this way 10 years ago. So obviously all data collection were collected, and we used one that was available at that period of time.
Okay, so we designed prospective 2 parallel arms, randomized control, monocentric and single-blinded trials. Only participants were blinded. And so it took us more than 3 years to complete that trial that was conducted from February 2014 to October 2017. All patients were recruited from our department in Paris, which is specialized in pain, spinal disorders. And so, as you can see, the main inclusion criteria were quite classical: adult patients with non-specific low back pain and a duration superior than 6 weeks. And the main exclusion criteria were, of course, specific low back pain, spinal surgery in the previous 6 months, motor deficit, pregnancy, and patient being manual therapists. And we recruited 400 participants that were randomized to standard OMT. So as Raphael fully described, it was 1 session every 2 weeks for 3 months. And 200 were randomized to the light touch sham OMT group. And our main outcome was activity limitations, mean change in activity limitations assessed with the Quebec Back Pain Disability Index at 3 months. So 0 means no disability and 100 maximal disability. And so we also pre-specified secondary outcomes based on the core outcome set of low back pain. So activity limitation with the QBPDI at 12 months, mean change in back pain and in health-related quality of life at 3 and 12 months, consumption of drugs such as analgesics and NSAIDs, duration and number of sick leaves, and number of acute back pain episodes at 12 months. And of interest, we also collected some variables that were not compared between the 2 groups, such as the credibility of interventions at 3 months, verbal communications during sessions at 3 months. That helped us a lot to probably better interpret our results and more classically adverse events and co-interventions. Raphael provided some details about the interventions, but we also implemented measures to reduce single blind biases. So all practitioners had to refrain from using the word osteopathy, during the sessions, but we did not use osteopathy also in the information sheet of the patients or in advertisements of the trial. Osteopaths were not allowed to see patients outside of the study. And well, we recorded all the sessions to further perform a qualitative analysis of 60 randomly selected recordings. So that helped us to analyze the verbal communication. And we also check the credibility of interventions at 3 months using a validated questionnaire, that is the credibility expectancy questionnaire. And our hypothesis to calculate sample was a difference in the variation of the Quebec score at 3 months between the two groups of 7 points of 100, which corresponds to the minimal clinically important difference for this score, and which represents an expected effect size of 0.35. So we describe qualitative and quantitative variables, and for the comparative analysis we conducted on an intention to treat basis this analysis. Variations in score were modeled using a constraint model of longitudinal data analysis, consumption of analgesics and non-steroidal anti-inflammatory drugs using the Poisson model, and other variables using a negative binomial regression. And for all comparative analysis, bilateral tests were performed with a p-value under 0.05 considered as significant. So now let's move to the results. So they were published on March in the JAMA Internal Medicine. And so we screened a bit more than 500 patients. 400 were eventually included and randomized in the trial. It was quite well balanced, of course, between the two groups. We lost some participants to follow up, but based on the intent to treat basis, we were able to include 197 participants for the primary analysis in both groups. So let's have a look at the population we included. It was, I would say, a classical population of primary care, a bit different from secondary and tertiary care, because probably limitations were less severe than this population. So mean age around 50, a female to male ratio close to 1. Most of people had higher education and were currently working at the time of the trial. The mean current low back pain duration was between 6 and 8 months, and the pain intensity around 40 of 100 points. And as I said, the Quebec score was lower than what we observe in people selected from secondary or tertiary care, around 30 out of 100. And interestingly, participants recruited in our trial had, for more than half of them, already been treated with alternative medicine, which include a big bundle of different interventions. And so that's the main result of our trial. So as I said, it was the mean reduction in low back pain specific activity limitations. So we saw a reduction of approximately 5 points in the standard OMT group versus 1 point in the sham OMT group. Which resulted in a difference of 3 points and a statistically significant difference. And regarding secondary outcomes, we did not observe any clinically or statistically significant reduction between the two groups. I mean, in low back pain intensity at 3 or 12 months. However, as you can observe, low back pain intensity decreased in the same range in both groups. We did not observe statistically significant difference in change in health-related quality of life. Interestingly, the difference in Quebec Back Pain Disability Index persisted at 12 months with a between group difference of 4 points. So as I mentioned, we had to report adverse events, even if this is a non-pharmacological intervention. So we did not observe an imbalance between the two groups. So we had some serious adverse events, but that were not obviously related to the interventions tested. And most adverse events were minor and mainly related to increased pain of back or other region of the musculoskeletal system. And so I would like also to show you the results of the variables we collected, such as the credibility and expectations of participants. So for that, we used a self-administered questionnaire that includes 6 questions about how the participant considered the interventions he received as credible, and the 0 means that the intervention was not credible or expectations were very low, and 9, the intervention was credible or expectations were high. And these results are interesting because even though we did not perform comparative analysis, we can observe that there is a systematic trend towards a higher credibility in the scores of the standard OMT. So that credibility might have maybe participated in the results we obtained. Another point to consider is the verbal communication. So we randomly analyzed the recordings of the sessions of 60 sessions, and we analyzed the 6 aspects of the verbal communication that were instrumental exchanges, listening quality, personal exchanges, quality of dialogue, reassurance, and relational proximity. And even though it does not seem to be such imbalance between the two groups, we can nevertheless observe probably verbal communication of higher quality, for example, for instrumental exchanges, listening quality, or relational proximity in the standard OMT group. So maybe verbal communication could also have participated in the results we observed. So how to interpret our results in the light of their clinical relevance? So as I mentioned, there were differences in variations between the two groups in favor of standard OMT group. For example, especially the Quebec score, well, the difference was 3 points out of 100 at 3 months and 4 points out of 100 at 12 months. That was statistically significant. However, there was no difference for low back pain. And interestingly, what we've learned from previous work is that probably the minimal clinically important difference in Quebec score is close to 20 points out of 100. It means that only a variation greater than 20 points out of 100 has a clinical relevance for patients from patients' point of view. And for low back pain, that MCID is of 30 points out of 100. So we at the reviewer's request, we also perform a post-hoc analysis and try to binarize the response criteria and to assess the proportion of patients with change in Quebec score higher than 20 points. And we could observe that this percentage was 10% in the OMT group and very close, 8% in the sham OMT group. So this absolute risk difference was not statistically significant. So basically, even the difference is statistically significant, the clinical relevance was really questionable. How can we explain these results? So these are only hypotheses, but probably the practitioner-participant relationships and practitioner attitudes towards the patient contributed to these results. As I shown, there was a slight imbalance of credibility, which may reflect failure of the blinding or a true imbalance in effectiveness between the two interventions. And there was also an imbalance in verbal communication, as shown by the analysis of the recordings. But also, and that was not fully reported in the main text of the paper, but there was also an imbalance in the treated anatomic areas. So as Raphael said, in the standard OMT group, the OMT focused on the regions that were considered as dysfunctional, whereas in the sham OMT group, all the regions were treated with the same proportion. So there was an imbalance in the frequency of treatment. And so all of these could contribute to some non-specific effects. And we know that they could explain up to 66% of the variance of symptoms in this kind of population. So as a discussion of the strengths and limitations of our trial, we mention the large sample size, well, more than 400 patients, and our efforts to control the non-specific effects in order to really addressed the manipulative component of osteopathic treatments. Some limitations were the monocentric study design and only one standard intervention that was assessed. So that was the visual abstract of the JAMA. I think that the main findings, we were able to answer our research question. That was that at 3 months, the mean reduction in low back pain specific activity limitation was higher in the standard OMT group versus the sham OMT group. However, and I explained to you why we believe the clinical relevance of this effect was questionable. And so our results also raise many further questions, I believe. So this is one of the figure of the paper. And as I mentioned, when we dichotomize our population between responders and non-responders at 3 months, we can see that we have some people that will not respond at all. So that means that we'll have no change at all in the QBI DI score, and they represent a high proportion of the participants we included. But on the other side of the figure, we can also see that there is a certain proportion of people, well, around 10%, that will have a spectacular clinical response on this scale to both interventions. So one question that we will try to address in further research is who are these participants that are likely to respond in a clinically relevant manner to manual therapy, manipulative treatments, either standard or sham, and who are those who do not respond to manipulative treatment.
Thank you, Christelle, for all these detailed explanation of the results and the discussion. So let's have a look now at what are the possible perspectives following those results, because obviously we were quite surprised. If you go back 10 years from then, we will be obviously very surprised to have this type of results. But like I said, a lot of things have happened and a lot of things have improved. A lot of evidence has been built in order to better describe what's occurring within osteopathic care. It means we used, historically, the profession used to focus only on the manual component and to forget or to not put that much attention to the non-specific effects. So the question is, there's a lot of options going on here. So this trial was not, the research question was not to evaluate the effectiveness of osteopathic care. We wanted to evaluate the specific effects of OMT within osteopathic care. So it raised the question of the importance of those contextual effects in manual therapy in general. So as Christelle said, 2/3 of the it considered 2/3 of the variation for chronic pain and 80% of variation for acute pain. It means that the exact same technique, the outcome can be increased or decreased depending on the contextual effects. So obviously this is really challenging for osteopaths who practice within the body-centered approach of osteopathic principles that back to 1953. But we are in 2021 probably, and probably we need to reframe the way we consider our our profession. So first of all, we have just put this slide in order to show that it might be difficult to understand for an osteopath. It's saying that 2/3 of the outcome are due to non-specific effects. But if we have a look at what occurring in other medical field, we can see that the overall effect size of the non-specific effects is 75%. So it's very common, even for medicine. So it's normal. Okay, obviously we had a different model, but no, I think we have enough data in order to move forward. So what are those contextual factors, especially in the manual therapy field? Testa and Rossettini, they have made a very interesting systematic review on those. So basically, they have the therapeutic outcome is rely on 5 different aspects within the body-centered model, the way I've been practicing for more than 10 years, and I've switched my mind little by little. I saw that the most important for treating my patients were to have a very accurate diagnosis, to find a lot of somatic dysfunction, and to be very specific in my treatment. That's the famous quote of AT Still: find it, fix it, and leave it alone. This was probably true back in the late 90s in the Midwest, in the US, but probably not today in our modern world. So Testa and Rossettini, they have described different important factors that can contribute to the therapeutic, the overall therapeutic outcome. The clinician characteristic, patient characteristic, the relationship, the way we build the therapeutic alliance, and we'll see in a minute that we can have, depending of the level of involvement of each patient, the therapeutic alliance might be slightly different. So the healthcare setting is very important and can contribute as well to the different to the overall therapeutic outcome. So in their paper, they have described all those contextual factors that may activate different circuitry within the brain that can have a nocebo effect or have a placebo effect. So obviously, when we describe osteopathy as a way to improve health, to improve the body functions, so it might be one option to explicitly describe what are the contextual factors and how to improve them. If we know that a specific attire or putting music or putting different things within the relationships, if we know in advance that it can help patients, it can improve the overall therapeutic outcome with the specific OMT, obviously, we have to do that. So let's have a look at those results. LC-OSTEO is for sure challenging the body-centered models for osteopathic care. But like I said, there's a lot of publication. There have been a lot of publication over the past 10 years that have been challenging these models. And now we have different options. Okay, so first, let's go back to the patients, the most important. You know, it's not just about describing models and so forth. The most important patients. So in this study, in the descriptive study from Giacomo Consorti, he interviewed many patients and asked them what makes an osteopathic treatment effective from patients' perspective. And the key things, the key results were that they all described that the therapeutic the osteopathic care always start with an experience of pain, an individual experience of pain. And little by little, patients, they perceive and they move their bodies differently. So it's not just contextual factors, you know. Touch is a very important aspect of helping patients to perceive their body and move their body differently. So, but it's not just an isolated on a body-centered approach. Obviously, LC-OSTEO is showing us that it's patients that can't make the difference between what we call placebo and what we call a real technique. In both cases, we are touching patients. So if we can control the contextual effects, we may really improve osteopathic care, and we may describe our specific skills in my opinion, much better way than what we are doing currently. So what are the different conceptions of osteopathic care? So Oliver Thompson nicely allowed us to use his figure. So basically, like I said, those three views of osteopathic care are already existing. Okay, we can see, and some views are very practitioner-centered, with the focus on the body, and there's a very low level of involvement. We know evidence is showing us that it's not the best option to help patients getting better in manual therapy. And there are two other aspects that are more recent in the osteopathic profession, and it's more patients or person-centered approach to osteopathic care, where the osteopath has a more collaborative or more is here to empower his patient. He's just here to help patients feel and interpret their symptoms differently, not only with touch. It's based on the person, what their specific needs are. So if we could summarize the evolution that has occurred within the description of the different osteopathic principles, we can see that in the past, the professions tend to focus on OMT and locally to improve tissular factors, meaning increasing range of motion, decreasing muscle spasm, increasing fluid motion, decrease inflammation. So we all know that. OMT at the same time has been described in order to decrease pain and to change the different circuitry at the spinal level. So osteopath in this body-centered approach is considered as a treater. All the treatment relies on the practitioners, and like I said, evidence is showing that the more patients are involved in their treatment, the more better outcome we get. So if we really want to consider osteopathic care within this person-centered approach in 2002, we really need to include patient management and include in the treatment the psychosocial factors. So let's have a look. We're getting close to the end. Have a look at what other options are available. So we are lucky to have Paul with us tonight. So if we have more information, if we request more information on this table, you may ask him. So basically, that's an editorial to the iGEM that was published last year. So it's just describing the different models that are available today. We have outdated models. We have models baked by science, where we can make some minor assumptions, and we have other models with a better level of evidence. So we have a choice. we have a choice if we want to, and it really depends on which type of person do we want to interact. And that's a very interesting question that LC-OSTEO is raising. Do we want to, as osteopaths, so I'm probably biased with my French environment. It probably doesn't apply to any of your country, any countries of where you're coming from tonight. But in France, as a non-regulated, as a non-healthcare professions, if we want to stay with those non-scientific models, we will only talk to osteopaths. We will talk only between us. And little by little, this profession will fade and no one will talk to us. So if we want to interact with other healthcare professionals, and in order to, we need to use this exact same language, and the better language to use when in healthcare profession is the language of science. So we can't explain everything. A lot of things are relying on assumption, but I think we really have the choice now on how we want to promote the profession. And Paul again is here, and he was part of the group who helped build the master program in Switzerland. So here we can have a great example on how a profession shifted from experience, sharing experience profession to an evidence-based, evidence-informed healthcare profession, and how the training shifted from private institution to academic institution with a more accurate use of evidence. So what's the role? What might be the role of OMT according to these more recent osteopathic principles? Obviously, patients, they expect OMT. They want to see an osteopath because they want to receive some kind of manipulation. And we need to know there are some specific effects, but they are very small, like we have seen, and patients, they can't make the difference. But we need to know too that those specific effects are associated with non-specific response. And I think it would be much better when we use OMT to promote sense making with an individualized narration for physical symptoms experience. What's the meaning of the symptoms for this patient, and how can we improve the patient's way of understanding and feeling his body? So osteopathic care should probably, and it's already the case, for example, for my colleagues from in the UK who are watching our webinar tonight, it's already the case. But for example, in other countries, I know Gerard from Spain is with us tonight, probably can comment anything. When it's not regulated, anyone can do anything, and that's not very ethical. And patients are not very protected with those options. So osteopathic care might include obviously OMT, but can include and incorporate many other things that are backed by science and that are known to improve patients' outcomes, such as pain education and encourage movement, encourage activity to promote reassurance and decrease anxiety. So that would be the end of this webinar, and especially where do we go from here? So that's our opinion. When I say our opinion, are the osteopaths with Laurent and Guillaume, who were very part of this journey. It's a real professional and identity challenge. Do we want to stay with pseudoscience, or do we want to move away towards science? The thing is, if we want to move away, if we want to move towards science, we need to be very careful, because there's already a profession that are using the best available evidence, that are using individualized care, that operating in a biopsychosocial framework. This is the orthopedic manual physical therapy. And that's all type of concerns. And what's the difference between the treatment provided by an osteopath or a physiotherapist or a chiropractor. So there's probably another way to describe the contemporary osteopathic care. So I have to apologize for my conflict of interest, because this is a paper that was published, that was accepted for publication yesterday. This is the end of the 2.5 year of work with many colleagues from different diverse institutions, European institutions. And so basically what we have done the paper, we have used the paper that was in this presentation, the MRC guidelines, to develop, so the 4 steps to develop complex intervention, and describing the osteopathic care within this body-centered approach this person-centered approach that considers each person as an interaction between body, mind, and spirit. And we are the only profession in the manual therapy using this body, mind, spirit tenet. So if there is some specific skills associated with that, we need to show that. We need to start investigating that. So for the acknowledgements, I can start to thank obviously my colleagues and good friends, and very good friends, because we have been quite challenged over the past few weeks. So Laurent Favre and from Paris, and Guillaume Krief from Lausanne in Switzerland, and obviously the 20 participants, osteopathic practitioners who participated.
Yeah, and so I would like to acknowledge as well the work of the Unité de Recherche Clinique of Paris Descartes that provided all the support to conduct the trial in the best conditions, and all the people who work in the department of physical and rehabilitation medicine of Cochin Hospital, who included participants as well. And our funder, of course. So it was an academic trial. So we were supported by the French Ministry of Health and Solidarities. And this study was funded in 2011. So it took us almost 10 years to have our results published. And finally, I will have some words for Professor Serge Poiraudeau. So he supported the idea from the very beginning, and was the principal investigator of the trial. But he passed away before we could publish this paper. And in accordance with the JAMA policies, we could not have him listed as an author of this paper. However, I think that all authors of this paper would like to acknowledge his amazing contribution to the work, and to honor his memory, because he was a researcher very involved in transdisciplinary research, very open to new research questions, even though those questions could question our own medical practice. And he was a very thoughtful mentor and a close friend. So thank you.
So thank you very much for your attention. Thank you for listening.
So thank you to both of you for this very clear presentation, giving us an overall view of the trial and going way beyond just your results, but also all this thought you've had on what does it mean and what we can do from there. So I'm going to already present the question that have been stated during the presentation. Feel free to continue asking questions in the Q&A section. We're not very much people around, so at a certain point, I can also hand over the microphone and you might be able to also state your own questions. So I might first tackle some maybe easier questions and with short answers, which are more methodology. So Andrea J. Rich asked the question, he wanted to know whether the osteopath had information about prior medical management of the patient. So did they have access to the medical records or not?
They had access to only the medical information that were recorded in the case report form. So basically, they were they were not the whole medical record. So just the data that were collected for the purpose of the trial.
Yes. And there's another question by Alain Bouchard who wanted to know how did we assess whether it was specific or non-specific low back pain? Was it with complementary exam, or was it following guidelines and it was more on a medical assessment?
So it was mainly on the medical assessment, but most of the patients who were screened already had imaging, either X-rays or MRI. And so those imaging were assessed as well, but they were not mandatory.
And then there's many of these questions that come together, and I'd like to address them afterwards because it really opens the discussion on the difficulties we have with contextual effects and placebo and non-specific effects. There was one question which was more about training and the degree of experience. Can you tell us a few words about also what we know from research on clinical outcome and practitioner experience?
Maybe Raphael.
Oh, I can't remember the paper, but basically in manual therapy, there's no influence on the type of practitioners and the type of level, the difference in professional status and the level of training when we investigate the specific effects. So obviously a patient, if he wants to see a healthcare professional, if you want to see a non-healthcare professional, the contextual effects will be totally different. And so, but when we focus on the specific effects, no difference.
Thank you, Raphael. So that rejoins the question, I think, Alain, that you asked also about the light touch treatment may affect different patients depending on the previous training. So that's also the question about when we construct the sham therapy, how do we actually know that the non-specific effect related to the sham therapy might be different between practitioners also related to experience? I think that's the way I understand the question.
Well, maybe I can take that one. I would say that even though we couldn't assess all the aspects of the sessions, we tried to assess some aspects, but we also tried to, in the training of the practitioners involved in the study, to control the other aspects of the intervention in both groups. So to do that, practitioners who delivered control, sham OMT, were the same practitioners who delivered the standard OMT. So probably
so if I understand correctly, what you're saying is that once you've created your design and you've chosen what effect you're actually interested in, after you're trying to dilute other what we will call non-specific, because it's not the ones you're looking for, you try and dilute them evenly. And this is all noise, but it will both affect the control group and the intervention group likewise, and that way you can actually dilute them. So in other words, you're saying it doesn't really matter whether or not experience might increase non-specific effects, because it will affect it as much in one group and the other, and it won't change what you're looking at, which in this case was, is OMT more effective than
so
than
the
light
effect,
touch?
well, if we consider that a part of the non-specific effects relied on the practitioner himself,
Yes.
which is probably true, the practitioners were well, randomly allocated to, well, they could deliver both interventions. So I guess that these non-specific effects centered on practitioner were, well, diluted in the same way in both groups.
Random error can occur. Andrea had also a question, which I might rephrase. And Andrea, if I'm not phrasing it appropriately, and if that's not what you meant, do not hesitate to rewrite into the questions. But apparently the design of the trial and the way it's done is also very important in the way we conceive or we module the care itself. So whether we are person-centered or whether we're more body-centered, for example. And so does the way we actually choose to do the sham or so on, and that the sham might be more body oriented and maybe the rest of the treatment might be more person centered, could that also have an effect? In other words, is it really the manipulation itself that might have effect, or is it maybe just because, well, I'm addressing regions that might have a better meaning for me? So again, even in the design itself, the effect that we observed, is it really related to the manipulation, or could it also be due to the fact that where we put the hand maybe had a more deep sense for the patients? Again, I'm not really sure if I understood that way, but I found there was that type of concept behind your question.
I said, those I can answer this. I can try to answer this question. In the sham group, we control that, as Christelle has said, the sessions were recorded. So the verbal communication was standardized in both groups. The length of touch was controlled. Okay? It was 15 minutes for the OMT and for the sham. And some practitioners may add went quicker, so they touch other parts of the body. So if you, again, with the evidence that was available at this period of time, we saw that the main component, active component of osteopathic care was the manual component. So we thought that when we designed the sham group, we really thought that we won't see anything. And at the end of the day, the patients, they can't make the difference. And the non-specific effect, the contextual effect, were controlled. We made the maximum efforts to control in order to isolate this very specific component of osteopathy.
I mean that during the last 10 years, we've moved quite a lot in the concepts we have with also what might take place when we're doing treatments. And that probably in the way we would manage all the patients, there might be some other components that could be considered. I'm giving examples such as probably that the patient is involved in their own interpretation of what they feel or what's coming through. So in other words, that once we do the palpation and feel different elements on the patients, there might be a conversation of saying, well, I don't know, like someone has neck pain and saying, oh, I feel your neck pain is more because of your position, and we have to release your chest or your upper thorax to release that pain. And then they understand why we're doing something, which probably in your trial you couldn't do, because then it would give given away when they're in the control group, because then it doesn't make sense what we're doing. So by that, I was saying, do you consider that maybe giving sense to what we do might also contribute? So giving a meaning to what people feel might also contribute. And this was not done in this trial, because as you were saying, we were more looking at the mechanical approach of the touch.
Yes, and there was a higher rate of credibility for the OMT group compared to the sham group. So in a way, it was a good sham treatment.
What if, just like a curious question, if we had to do a trial today, what would you use for sham? Would you reuse the same type of sham? Would you improve it? How would you redefine the sham? Maybe it's a tough question because probably you would also focus on intervention on other components.
Your research question.
What can you, maybe in your experience of developing that sham, what would you advise any of other people over here in saying, well, what's important when you're doing the sham and what you really have to consider from your experience?
It depends on what would be the research questions. Apparently, we reach the maximal effects as soon as we touch patient. That's the way I can interpret, and that's the way that's the physiological work I've been doing during 2 years in the United States. We reached the same conclusion. The body there is a systemic response, and patients, they can't make the difference at the physiological level. However, like you've just said, the meaning and the sense making is key in order to help patients feel and interpret their bodies differently. And osteopathic care is very appropriate for that, because we spend a lot of time with our patients. We have time to not to focus on the biomechanical aspects of things and what's going on in the lab. All those psychosocial factors that are known to be key in the outcome.
So Andrew was actually picking back up the first question that he was asking. He was more saying, are we really testing one form of OMT with another? Or what are we actually truly comparing effectively between the sham and the true intervention? I'm not really, so I don't know if it's the mythology in saying, well, one is without intention and it's preconceived areas, and the other one is what we do is in osteopathic care. So I don't know if he's asking, what does this mean? If we have little differences, what does it mean in a broader sense? Probably that's what, or because he asked, are we really assessing one form of OMT with another?
Thank you, Andreas, for this question. I forgot to mention that practitioners during light touch, they had to count in their heads. So the attention was distracted too. And obviously in the OMT group, patients, the practitioners were focused on treating the somatic dysfunction. But that's another key important difference between the two groups. So I don't know if we can consider this type of sham treatment as an OMT. Maybe for 8% of the people, it was a real OMT, and we should be happy for them, and we should ask our question and not blame patients why they responded to the sham placebo. So.
It also might mean that one day I'm very distracted and I'm not very concentrated on what I'm doing with my patients. And I might still have some outcomes, because sometimes that's not all what it takes for them to feel better. So sometimes it's putting a bit less pressure on practitioners and maybe having us focus more on the way we manage patients with other aspects. So thank you. Another question that we've had was really related more to communication, because I think you've had all this secondary analysis, and I think we realize the work this must have been to film and to collect information on the amount of time that's touched. This is a huge amount of work, and I think it's a really precious database that describes actually what osteopaths do. And there was one question saying, well, what was it at the communication level, and how did people manage to communicate about the sham therapy?
We did not disclose the words osteopathy or sham osteopathy actually, but only we talked about manual therapies only. So we did not mention osteopathy or sham to patients.
So that means
they were blinded.
Yeah, and were most patients naive patients toward osteopathic care, in the sense it never told them it was osteopathic care? And were these patients already attending osteopaths, or most of them had never had any form of either manual treatment or osteopathic care?
So this was one of the characteristics of our population in the table 1. More than half of them already had alternative medicines. So probably not all of them were naive of osteopathy. So maybe they could have guessed what
We've
they
had
received.
trials done in osteopathic schools, and we've used similar approaches with sham, and then asking them in what group they thought they were, and they're just as naive. So today we're starting to believe that it's not related to prior experiences, and that it's also possible to deceive even people who have already seen an osteopath. I'm maybe grouping 3 of Alain's question in one global question, which is this big element between sham, non-specific effect, and how should we start investigating different components that we might enter into non-specific, which means that from the moment we're starting to analyze them, they don't become non-specific, they become specific. So maybe we could call them also, there can be now some active non-targeted effects, and therefore, how can we consider in the future to maybe start investigating which of these components could be there? And then also, if we accumulate different trials, how could we start collecting information or doing meta-analysis on these subcomponents? So it's more on the methodological issue and a thought for future researchers in complex trials, to be able not to just have a model that's constructed afterwards, but there we're actually assessing studies or treatments that are already underway, and many of the components are probably related to just mimicking people who've done things before, and some of these things are useless and some of them might be quite useful. So how do we actually go and explore, and once we know which effects could be potential, how do we start investigating them without having to run 30 10-year trials, which would be impossible in an economical perspective?
Well, I guess that it would be, well, I'm not a specialist to that kind of question, but I will give you my opinion as a trialist and a clinician. I think that it's quite difficult to assess individually all the effect size of all the components of a complex interventions. And I'm not too sure that's interesting from the clinical point of view, because as we all know, we do not deliver standalone interventions, but a bundle of interventions. And at the end, if we improve patient important outcomes, whatever it's this component more than the other, it might not be so important. So I guess that we can move to more pragmatic trials rather than explicative trials. And I would say that LC-OSTEO was a bit between explanatory and pragmatic trials, but it was not very pragmatic actually. So probably we have to accept that we might not be able to explain the contribution of each components of a complex interventions.
Yeah, and also we don't even really know. We are starting to have a good guess of what it could be. I think Kapchuk and their team have done some really interesting also paradigms when investigating different what we would call non-specific effects, but that we actually see in many of care, whether it's psychology, psychotherapy, or osteopathic acupuncture, and all these different disciplines, where in their training that we're actually using these components in care. One also element that's rising is phase 4 trials. One of the big limitations that we might see with complex intervention is that during a phase 3, if we define an intervention, even if it's a complex one, it seems like we would have to deliver exactly the same way as it was done in the start, because if not, we don't know whether if it's effective or not without doing a new trial. But we can't, each time we add a new component, redo a trial, which means that either it will standardize the treatment and we won't be able to innovate and bring in new knowledge and improvement within what we do, or we need to have a lot of money to do the trials. And phase 4 might start having more large monitoring, and we can implement innovations iteratively, so don't bring it everywhere at once. And then we can start seeing whether there is added benefit from small added components. And that would make it possible to keep innovating without having to run a trial. Another approach that we might start considering is, rather than testing and adding a component, so doing factorial designs and putting more than one intervention, so you can put the manual component and maybe something like a soft touch, so the contact at the start of the treatment, or whatever component we want. It's to be able to have a list of maybe 12 or 13 components we do think that osteopathic care uses. And then within each clinical trial, we do a factorial design, but rather than adding it, we remove them, which makes it much easier for clinicians also to say, I'll randomize with you, but apart, I won't speak to you about this factor. I won't do such and such. And they're still giving the overall treatment, so it won't change a lot in their overall effect, which is much more acceptable. And then when we combine these trials together with meta-analysis, we could start observing what actually happens when we remove a subcomponent. So this is more like a general, where we have to start considering that when we do a trial, we might add in certain elements that we can't use with that trial, but that the data can be reused in the future to answer these more complex questions. So there is a form of feeling, and I'd really like also maybe if Gerald has some elements to compose. He's doing his PhD on these topics, on challenges with clinical trials. I don't know if he has any elements he can point out, but he can also maybe give his views on what are the challenges we have in improving methodology for complex intervention, and where can we go from here, knowing that we don't have a lot of financial resources. And like he said, I would say you're not expecting to receive that amount of money to do a trial in osteopathy like every year or every 2 years. And therefore, how can we get organized in the future to be able also to answer patients' needs, and also identify what's best that we do to improve the care we offer. So I don't know what your views are about these more collaborative approaches, and your vision also on secondary analysis, how data can be reused. If you have a few words on that topic. Also in the view of science, how it's also a collaborative approach, and how can you actually serve beyond just the trial and the budget that was provided for the trial?
Well, so I can start with it was very important, of course, to collaborate from the very beginning of this trial, because we all know that, well, we could all see that our specific fields could complement each other, and so that was important in the design, but also further in the interpretation of our results, because we could highlight the main points of the results by interpreting them together. And for further research, I think that as any trial, this one also raises new questions, and also helped us to have a huge amount of information that still needs to be analyzed. And so I could see some questions in the discussion, for example, how the experience of practitioners could influence results to sham or standard OMT. So that's very interesting, and I think that we have the data to answer that question, but also what is the phenotype of participants who responded to both sham and standard. So, well, the data set is open, I would say, to scientists, as long as they ask a research question and propose a methods that will be appropriate to address those questions. So I would say that there are many exciting perspectives.
Is this something particular because of the funding approach, or is this something that you generally do with your studies, and you're finding that generally in health research, we're starting to make data more available to other groups?
Well, that's a policy that editors endorsed well in the past few years to make as possible data available to other researchers, and I guess that we were quite well, we quite agree with that that approach of open science, because of course these data are not ours. They can contribute to advanced knowledge in the field, and probably that other people also have very interesting questions that could
It's
be
because I forgot to mention at the start that you're also an editor for PLOS Medicine. PLOS Medicine is indeed an outstanding journal that came, well, I wouldn't say of nowhere, but it was a surprise for the Big Five, who didn't expect a new journal that was not under paper form. And I think it's the first open source web-based articles that started really to show the difference in the impact factors and so on. And indeed, I think it's journals like BMG Open and PLOS Medicine, and now all the rest of this year we have JAMA Open and so on. And they're really leading into this open science approach. Also sources of work for master degrees and so on, who can reuse that data, which does not often require going through ethical committees and also bothering patients. Gérard asked for a moment, did you consider at any point of having a 3-arm trial and having a waiting group? And if not, why?
Well, the waiting group, well, I think wouldn't be that useful to explore the effect of the sham, because it's just a natural history of the symptoms, but in people participating in the study. But we will probably lose all the effects of sessions, repeated contacts with care providers as well. So I'm not.
There you're really saying that's depending of the research question, and given that it was more focused on really what does the manual approach and the contact of the correction of what we felt that was assessed, it wasn't very useful having a waiting list. I'm saying that also because the BEAM trial had a 3-arm design. Well, they actually even more, because they had exercise plus manual therapy. So they had but they did not have sham. So they had many arms. They had a waiting list. They had exercise alone, manual therapy alone, and manual therapy and exercise. And Alain has a question more on representations and what you do and how it works on, and was mentioning more clinical experience with disc herniation, and saying that often patients come with mild imaging and back pain, and therefore instead of working on the area where people also represent, maybe have are a bit scared of what's going on, and they might dramatize their own, then they choose other techniques such as cranial techniques that could be associated with the sham that's there. And so how can we now start modeling these thoughts and saying, well, in what context and what are we doing with patients when we're using such techniques, which osteopaths apparently already use, such as saying, yeah, I use that sham approach all the time. So how do we conceive that, and how do we integrate that in the way we see what we do? In other words, once we move back from the model saying, oh, there's a somatic dysfunction and I'm removing it, what am I doing then?
You're helping. This is a key question, and I don't think anyone can answer that, and that's why we within the foundation we will create a specific department to start investigating all those person-centered approaches. Obviously, we need to touch patient, and we won't do that randomly. It just need to make sense to participants, and to participants or to patients. Some patients they know that they will improve only if we touch with gentle touch over the skull, because of their belief system, and we don't know why. And others they have expectation that they will improve with manipulation of remotely from the pain area. And we don't know why. This is why it is important to be very person-centered in order to make sure that the osteopaths can provide this type of manipulations that they would prefer. So basically, this is just a personal assumption. So what we need is we need qualitative study, and in order to ask patients what's the most important for you when you visit an osteopath, and probably we would be surprised.
I think there's also a lot of work, and we're seeing many osteopaths who are doing their PhDs in neuroscience. I'm not saying that because I did my PhD in neuroscience, but there are a lot, and we can see that this is also bringing new insight. And when you look at publications, the way touch is influences our perception. There's very little research done on that. There has been these last year, given the haptic approaches with electronic devices. So to create the illusion of texture or softness or so on. But on the other hand, of embodiment and how we perceive our body, how we can create trust or ignore a region, there's very little that's been done. So there's also, I find, some questions about how do we merge clinical practice and more clinical research to more fundamental research, and the need also to create better paradigms to be able to test questions rather than just do observations, to do the qualitative approach, to start creating potential theories, and then do experimental design that actually challenges these theories to see what's happening. So in other words, it feels like we have to create the osteopathic science that can carry our profession and move forwards. And I think you're already doing quite a lot of that, Raphael, with your work. And I think you feel like you could do that all your life. We keep having questions.
I'm a clinician mainly. That's the most important.
No, I know you're a clinician, but I don't know. You, yeah, of course you're a clinician. But we worked on a recent trial. It was a qualitative study that was focused on the process of touch and how do you move forwards on the decision process of what you need to do. And what was observed that it was an iterative process. And then we looked at how the participants were actually describing what they did. And we noticed that they had steps, no, they were working, was exactly the same way as the new approach for the MRC of how we develop complex intervention. And so it seems that the way that an osteopath is actually managing their patients, they're creating a personalized intervention for each patient. So when you're saying, I'm just a clinician, so yeah, of course. I think osteopaths don't realize they're all researchers, but they just research for each patient. They have like a one subject research element, but the process that's moving forwards in thinking and finding solutions for patients is very similar to what we do in research, except there maybe we move a bit back and we start really questioning and putting in designs. But I find research to be much closer to our clinical application than what we usually think. It's not because we don't have a history of including research in our training, that it's not elements that we really need as practitioners. That might be my personal opinion, but so I believe you're a clinician and a researcher in both, and quite good in both. What was Anna saying?
One more question.
Yeah, one more. I think chronic low back pain also often has a big psychosomatic component with this. Was this aspect also considered? So I think there were many questions that are around, was any elements, so the multidisciplinary approach, was there discussions around or not, which would affect both groups and might explain why there was some good effects in both groups. Can you just tell us a little bit of what was put in to provide the best care to the patients?
I went through a bit quickly, but in table 1, we summarized all the interventions that participants had, and they had this multidisciplinary approach in both groups. So they had physio and medications, and they had GPs consultations. So before entering the trial. So there was a multidisciplinary approach adapted to that population that was not a population of secondary or tertiary care again. and but it was not assessed in the interventions of the trials.
So I'd really like to thank you both again for your presence today, for all the hard work you've put into this trial. This is 11 years of work. I'd like also to thank all the discussion that it's led in the osteopathic community. I think it's made us grow. I also think that the way things were presented and the scientific honesty that was behind everything that was there is really, I think, an example for how we want trials to be, and we can see the effort and the quality in what was done, which explains why you were able to publish in JAMA Internal Medicine, but also to what extent we can actually do high quality trials to answer questions we have in our disciplines. And also that independently of results, once we do a trial, it actually builds the profession forwards. And I think your contribution with these elements where there are some effects, but them alone don't explain everything, and that has risen all the questions about complexity, will probably help to change also the vision of osteopaths have of why they're good and what actually helps their patient, improve education. And I think it has a very, very big impact on the profession. So thank you again for all your work and for spending the time with us to talk with us and answer our question. And I look forwards outreaching back to your future research and seeing what's been done, because I think in complex interventions, there's so many things to do. Most likely everyone will be around here will be digging their heads to make it work. Raphael, I don't know if you have a last word.
No, thank you, Paul, for the nice, very productive moderation tonight, and thank obviously Collaboration for organizing this webinar, and the EFO who promoted this webinar as well. We really wanted to go outside the French context and have a more professional, in a more professional context, just focusing on data and how to move forward, and what are the different options. Because if we get stuck in one option, I can see a bright future for the profession. So, and I'd like to thank Christelle obviously for the time again spending with us in promoting the results of this study, and for our collaboration with us. So that was a wonderful journey for us. So thank you again, and thank you Paul again.
Yeah.
So all have a great evening, and thank you for the register. So this recording will be made available. So in a couple of days, you'll be able to go in through the same logging and re-watch certain parts. Some people have asked to have the references because I was posting them, but I think you can't copy and paste them. So I have a file, and I'll see with Carlotta if we can place it somewhere. I'm not sure if it's possible or not. In case it is a problem, just simply send an email asking that you want it, but we'll try and send it to all the attendees. So I might just ask Carlotta for the list of your email addresses and send you as a BCC so that you can receive it all. So thank you again for your participating tonight, and see you soon. Goodbye.
Bye.
Bye-bye.